A very good evening to all of you, my friends. I am Dr. Vivek Nangia, Chief of Pulmonology for Max Healthcare and Principal Director and Head of Pulmonology, Critical Care and Sleep Medicine at Max Hospital, Saket. It's indeed an honor to be present on this prestigious platform, which is very educative and has been running extremely successfully for the last so many webinars being conducted by the Indian Chest Society under the able guidance and leadership of Dr. Amita Nene, Dr. Rajadhar, and Dr. Sandeep Salvi. This is a complete series on ICU, probably the first of its kind in our country that we are holding it. I would also like to express my gratitude towards CIPLA for supporting this and supporting so many other activities that they do for us from time to time. Today's topic of discussion is tracheostomy. Tracheostomy, which is a surgical procedure to create an opening in the anterior trachea to facilitate the respiration. Historically, we've known about it since about 3600 BC, and there was a time when it was represented as the only treatment available for upper airway obstruction. From then to now, the indications have widened over the years, and so has tracheostomy evolved from a time when it was in the domain of only the surgeons, the ENT surgeons or the thoracic surgeons. It has now moved on to us, the pulmonologists and the critical care specialists. To talk about tracheostomy and all the aspects related to it, we have a very avid speaker this evening with us, none other than Dr. Rajesh Chawla. Can we have the introductory slide for Dr. Chawla on, please? Dr. is a senior consultant in medicine. He is the past president of National College of Chest Physicians, past chancellor of Indian College of Critical Care Medicine, and the past president of Indian Society of Critical Care Medicine. But apart from that, I would like to share with you that is literally a household name in the field of pulmonary and critical care medicine, amongst the first ones to integrate pulmonology with critical care, and and has immense contribution in both the fields, pulmonology as well as critical care, having written many chapters, many books, many research work, and probably countless lectures in both the specialities. After his talk, we'll be followed by a panel discussion. And for our panel discussion, I'd like to introduce the panelists also. Uh, to begin with, we have Dr. Shyam Tampi with us. Can I have his slide on, please? Okay, so this. So, okay, so we have Dr. Shyam Sundar Tampi, who's a DM from PGI Chandigarh, FCCP USA, currently working as a senior pulmonologist and physician at Bombay Hospital and Medical Research. Then we have Dr. Unnati Desai, who's an MD Pulmonary Medicine, Fellow in Interventional Pulmonology, currently working as Professor Additional and HOD Pulmonary Medicine at the BYL Nair Hospital, Mumbai. She's actually been responsible for formulating the guidelines of thoracoscopy. She's contributed immensely to those guidelines, really. I mean, we all have contributed probably a very small fraction, but major contribution has come by her in compiling all the data that we collected and gave to her. Thank you so much, Unnati, for that. Our next panelist this evening is, can we have the next slide, please? Dr. Abha Mahashur, who's again a DNB from Indraprastha Apollo Hospital, IDCCM, and is currently a consultant pulmonologist at Leelavati Hospital, Mumbai. Next slide, please. Next, we have Dr. Tampi, I've introduced already. And then we have Dr. Neel Thakkar this evening, who's also a DNB and EDRM from Paris. He has several presentations to his credit, several publications, and is currently working as consultant pulmonary and critical care physician at the Pulse Clinic and Sterling Hospitals, Vadodara. So we have an extremely illustrious panel this evening for you, right from Mumbai, Delhi, Vadodara. So all of them together to enlighten all of us. I feel every time we have a session like this, we also all go back so enlightened. So I'd like to request Dr. Chawla to start his presentation and give us an overview of tracheostomy, and then we'll go ahead with our panel discussion subsequently. So over to you, Dr. Chawla.
Thank you, Dr. Vivek. Can I have my slides, please? Hello. Hello.
Vijay, can you put up his slides? Okay, so Dr. Chawla, you would probably start in the meantime.
Okay. The whether you are a physician or a chest physician, intensivist, anesthetist, surgeon, the tracheostomy is somewhere or the other you will encounter in your life. And you have to know, because many a time there are very small things and you really don't know what is the answer. So I'm going to make my presentation extremely simple, and I'm going to tell you on day-to-day practice what we encounter, and also I'll tell you about the procedure also. Next slide, please. So, tracheostomy is the opening you make in the trachea with an incision. And, it is actually I cut trachea in the Greek word. That is the meaning of this. Next slide, please. So, it is not that we have invented tracheostomy. It has been there in Egyptian artifacts, and even in Rig Veda, there is a mention of tracheostomy. Next slide. I think we need to know about the basic tracheal anatomy if we really want to discuss about tracheostomy. As you can see in the slide, the trachea lies in the midline of the neck. It extends from the cricoid cartilage, that is C6, to the tracheal bifurcation, that is T5, and it comprises of 16 to 20 C-shaped cartilage ring, and length is about 10 to 12 centimeter. That is the usual basic anatomy one needs to know before entering into the learning about the tracheostomy. Next slide. What are the indications of tracheostomy? It could be an emergency tracheostomy or it could be elective. As an intensivist or a pulmonologist, we normally do not encounter that much of emergency tracheostomy as much we do elective tracheostomy. But when a patient has acute upper airway obstruction, who's failed intubation with an endotracheal tube, or in whom an endotracheal tube cannot be inserted, like patient comes with acute upper airway obstruction because of anaphylaxis, because of angioedema, and you can't insert, then you need a tracheostomy. Patient with select fracture of the oropharynx and neck, that is another indication. And trauma patient with particularly penetrating laryngeal trauma, that's another indication where you would require an emergency tracheostomy. But most of the time, next slide, what we require is a elective tracheostomy. As far as I can remember, I think where I required tracheostomy was when there is a problem in weaning a patient from the ventilator. I've been ventilating for a long time and I have to wean off. That's the commonest indication as a pulmonologist we encounter, and we do a tracheostomy in our patients. Then the other group, very important group, is poor airway protection. Patient who has a neuromuscular problem, the secretion control is not there, associated with bulbar weakness or recurrent aspiration, that's another indication. Then to prevent and treat the retained secretion, patient can't cough it out, and you do a tracheostomy. Then patients who's got a subglottic stenosis, which is not responding to the conventional therapy. Severe vocal cord paralysis, whether it is an abductor or adductor, these patients also require tracheostomy. And then you are doing a surgical procedure, and sometime in some certain surgical procedure, you do a tracheostomy. So these are the main indications of elective or the emergency tracheostomy. Next slide, please. Now, it is also important to know where not to do it. Cellulitis of the anterior neck. Whenever there is infection, please don't do it, because it will not only cause problem immediately, but also patient can go into shock. So you should not do it. Unstable patient who's on a very high vasopressors, patient who's requiring 80-90% of oxygen, uncorrectable bleeding diastasis. Patient has a bleeding tendency and you've not been able to correct it. There is a gross disruption of the neck due to hematoma, tumor or thyromegaly or scarring, or sometimes there is a because of radiations, and a high riding innominate or thyroid internal memory artery. That's more of a contraindications for percutaneous, but of course surgical tracheostomy can be done by a surgeon. Next slide please. Then, as I said, a patient who is on FiO2 of more than 0.6 and PEEP of above 12, an obese person with a very short bull neck that obscures the anatomic landmark in the neck, that is again a relative contraindications, and you are not able to extend the neck. There is a cervical fusion, rheumatoid arthritis, or other cervical spine instability. These are conditions where it is very difficult, and usually the surgical tracheostomy is preferred, but percutaneous tracheostomy is really not done in these patients. Next slide, please. So what are the advantages of tracheostomy? It, of course, reduces the work of breathing, improves comfort, facilitate weaning, better secretion control, lower incidence of tube obstruction, less oral injury, and reduces laryngeal damage, better oral hygiene. So there are a lot of advantages of tracheostomy. Next slide. Now, when to do it? This is always a debate when to do it. Somebody will say we do it 7 days and 10 days. But 7 to 14 days is the usual time we do it. I personally do not do a tracheostomy before 10 days of a patient on a ventilator. And there is a concept of early tracheostomy and late tracheostomy. Early tracheostomy is when you do it before 2 weeks, and late is when you do it after 2 weeks. Next slide. And if you compare, next slide please, if you compare the early tracheostomy with the late tracheostomy, there has been a similar survival at 1 month, improved short-term clinical outcome. Early tracheostomy did not change any outcome at 1 year. So practically, as far as the outcome is concerned, there is not much difference. Next slide. There are observational studies, randomized controlled trial, even a recent meta-analysis published. There is no difference in as far as the mortality or the ICU length of stay, whether you do an early or late tracheostomy. So what is the ideal time? I think about 10 days. If you're considering patient on a ventilator, that is about 10 days you do it. Sometime when you feel the patient has neurological illness and you suspect the patient is going to be like a cervical fracture or something like that, patient is going to be on a long term, then probably you could do an early tracheostomy. But usually make patient stable and then do it. Next slide, please. Then in COVID-19, tracheostomy, as you know, is an aerosol generating procedure. So it is always advisable that you should delay it, and ideal time would be 14 to 21 days. Next slide. So now what are the types of tracheostomy? It's a surgical and percutaneous. Every one of you know it very well. If you compare, next slide, please. If you compare the percutaneous with the surgical, there is a lot of studies and there is no difference in mortality, intraoperative or post-operative bleeding risk. Of course, the surgical is done by a surgeon, and PCT can be done by a surgeon and as well as by physicians. And of course, they found there was a lower incidence of infection if they pooled and short procedure time with the PCT. Next slide, please. And there are various techniques. Griggs forceps technique to dilate the stoma and put the percutaneous. Fenton's technique of percutaneous tracheostomy. Kejalia, blue rhino. But what we nowadays practice is an ultra-prec single stage dilated technique, which I'm going to show you also. And that is, which is very easy, very safe, easy to learn. And that is what is practiced. Of course, it is a little expensive as far as the set is concerned, but this is the most safe percutaneous tracheostomy. Next slide, please. So why this single stage dilation technique? Because it's a very simple technique, can be done on the bedside, does not require operating theater, possibly less wasting time for the patient, and associated with less periosteal bleeding. Next slide, please. So when you're planning a percutaneous tracheostomy, you prepare the procedure, set the, a PCT set, whichever you decide, which company you decide, bronchoscope and its attachment, like swivel adapter, where you have to put through an endotracheal tube, ultrasound machine, continuous monitoring of ECG, blood pressure, and oximetry. Most of the time, patient is already on this. IV access, sterile setup with enough sterile linen. Next slide. Then you need a crash cart with laryngoscope and endotracheal tubes and emergency drugs, suction equipment. You need a sedating and paralyzing agents, 1% xylocaine with epinephrine. Next slide, please. Then you need to form a team. One is the operator. Then you require one physician who will manage the tube and take out the tube and the another person, paramedical, who will assist in bronchoscopy, and another medical or paramedical who will monitor the patient, monitor the oxygen and the ventilator when you are doing the procedure. Next slide, please. Then there are different types of tubes are available. One needs to know there is a cuff tube and uncuffed tube, fenestrated tube and unfenestrated tube. Fenestrated tube is when there is a hole in the tube, and it could be with an inner cannula or without inner cannula or with subglottic aspiration. That's what is preferred most of the time in a critically ill patient with a cuff tube. Next slide. This is just a picture to show you the various part. It has a cough, a tip, the shaft of this, there is a flange, and there is an inner cannula which you can put sometimes in these patients, and there is a inflation wall by which you inflate the cough. Next slide, please. And this is just to show the inner cannula. Normally, if there is an 8mm size tube, the inner cannula will make it about 7mm size. So it reduces the size of the lumen and also increases the resistance. Next slide. This is another slide to show you the inner and outer diameter. Inner diameter of 8mm tube, it has a 11.4 millimeter, the outer diameter of the tube. Next slide. There could be angled tube and there could be straight tube. One needs to know but most of the time it is the cuffed and the curved tube which we use. This is what is fenestrated, because many a time you want the patient to speak, and in those cases where patient can protect airways, you use these fenestrated tubes to make patients speak. And this is just a picture of the various part of the tracheostomy set which we use. So when you are preparing a patient, there are few other things which one needs to know. Next slide. Next slide. This is a fenestrated tube. Next slide. This is a set. Now, when you are preparing a patient, you withhold anticoagulants. Clopidogrel should be held at least 5 days. Warfarin, you should hold for 3 to 5 days. And INR should be less than 1.3 to 1.4 when you do. But there are cases in the literature where you could not stop clopidogrel. People have done PC2 without much bleeding. So if there is really need and patient is on this, you can do it. But ideally, if it's an elective procedure, you should stop it. You should explain the procedure. You should obtain the consent. Patient should be fasting for 6 hours. Aspirate the nasogastric tube again immediately prior to the procedure, and prepare all required equipment. Next slide, please. Then you must check the tube after inflation of the balloon. Sometimes there is a leak and it is really embarrassing. You put in a tube and the balloon is leaking. So you must check the dilator, check the introducer and tracheostomy so that you don't have a problem. Then patient is given the sedative and paralytic agents. Usually patient is intubated and you give propofol or an opioid along with neuromuscular agent. Next slide. You change the ventilatory setting. Next slide, please. Change the ventilatory setting to FiO2 of 100. Tidal volume is increased to compensate for the air leaks. And you will have to adjust alarms so that if there is an increase in the peak airway pressure, it does not cut off. And patient's eyes are closed, of course. Next slide. Patient should be supine, of course. And you put a towel below the shoulder and extend the neck. And you give a support to the head with a ring or a small pillow. And then mark the landmark points. And you should mark the sternal notch, the thyroid cartilage, and the cricoid cartilage. Next slide. So, I will now discuss what is the role of ultrasound and bronchoscopy in doing percutaneous tracheostomy. Ultrasound is really emerging as a very great tool to help finding out not only the place but also to guide the doing a percutaneous tracheostomy. So it can help you to identify the pretracheal vascular structures and can really give you the site where you need to put in. As you can see on this, if you put the linear probe on the trachea, the upper picture can show you, if you see this. Next slide, please. So as you can see, the first one is a thyroid cartilage, then there is a cricothyroid membrane, and the second, which you see as a hypoechoic area, is a crical cartilage, and then there are rings. So you can really choose second to third where you have to put. And the other advantage of ultrasound is that you can rule out there is no high innominate artery, because if there is there, then it can really bleed when you do a PCT. So these are the two very major advantages of the PCT. Next slide. But what most of the people nowadays practice is the bronchoscopy. So what you do is when you start the procedure, you have draped, you have given the local to the patient, and then what you do is that you start with a next slide, please. Next slide. As far as you compare the ultrasound and bronchoscopy, people have found there is no difference in the bleeding or in the guidance or the success rate. So this is the first step, that through the swivel adapter, you put a bronchoscope and you take right down to the carina. So now you start withdrawing the tube. Next slide. And when you encounter the subglottic area, this is the area, as you can see, the tube has reached the subglottic area. That is where you now again deflate the tube, which you had, inflate the tube, which you had deflated just above the carina. So next slide, please. So now this is the subglottic. Next slide. Next slide. So now with the bronchoscopy guidance, you make a puncture into the trachea. And as you can see, between second and third cartilages, that is the ideal site. You should not put it too low. And as you can see, the needle is coming out. Next slide, please. And this is this needle which comes out. It is with a cannula. And once you see that you have reached inside, you push the cannula and take the needle out. Next slide, please. And then you insert a guide wire through this cannula. Next slide. And this is the guide wire. So you first introduce the needle with a cannula. Once the needle is in, you withdraw the needle and kept the cannula there. And then you have put in a guide wire and you now withdraw the cannula. And as in the picture, you can just see the guide wire going down. Next slide. Now there is a dilator which you put it to dilate it further. And that is a plastic catheter, as you can see, white. Next slide. And now once you've dilated, then with a guide catheter, nowadays the dilator is available along with the guide catheter. So the guide catheter along with the dilator, now you put into the guide wire. And as you put it, and then you dilate the stoma. That is what it does. Next slide, please. Next slide. And as you can see, you're pushing the dilator and you have dilated the stoma. And now, once you are finishing this, you have already loaded the tracheostomy tube into a introducer. So what you do is now you withdraw the dilator, keep the guiding catheter inside, and then over and above that, you put in a tracheostomy tube. Next slide, please. Next slide. And then you have withdrawn the dilator, and on that guiding catheter, you put in a tracheostomy tube. As you can see, the tracheostomy tube is inside, and then you withdraw the introducer. And next slide, please. And as you can see, Now you've reached and you place the tracheostomy tube 2.5 to 5 centimeter above the carina. So that is the site where you will keep it. Next slide. Then you remove the bronchoscope, and then it is inserted through the tracheostomy tube to confirm the placement of the and visualize the trachea, and you can clean up, and then you can attach the ventilator. Next slide. So to confirm, if you are not doing with the bronchoscopy guidance, of course, the chest auscultation can help you. Capnography will help you. And if you are doing bronchoscopy guidance, there is no better method than bronchoscopy to see that it is inside. And then if you are doing, you can see on a ventilator the tidal volume, and you will see the graphics very clearly. So it ensures that if you're doing blindly chest auscultation, capnography, and tidal volume return, but you're doing bronchoscopy, then bronchoscopy is enough to confirm that you have placed it nicely. Next slide. So just to revise, you mark a landmark, you needle injection, guide wire insertion, introducer, dilatation, and tracheal tube insertion. Next slide. I'll just pass a word about the Surgicel. This is a absorbable hemostat, oxidized, degenerated cellulose. Sometimes, there could be a bleeding around the tracheostomy tube. So many people put a purse string suture also before doing the tracheostomy, so that if there is a bleeding, they can tight that. But what we normally do is we put a Surgicel. If there is a little bleed, this is an absorbable hemostat. You can put it around the tracheostomy tube, and most of the time, small bleeding is stopped by this. This is easily available in our country. Next slide. And then you secure ties. You can directly put a Velcro ties, or next slide, cotton ties, which is sometimes in our country people use it. Next slide. Suture. I normally suture the tracheostomy tube, because when our nurses, they do a nursing early in the morning, the tube can come out, and we normally suture when we do a initial tracheostomy for 5 to 7 days. We always suture it. But there is a study where they compared whether to suture or not to suture. They even found that decannulation was not found to be associated with future suture replacement. But in our country, I still prefer to put a suture rather than just putting a Velcro initially. But after 5 to 7 days, when the track is formed, you may just put a Velcro strap, and that is more than enough. So next slide, there are certain complications which can occur. The immediate, as I said, hemorrhage. You could go into loss of airways. It could get displaced. Pneumothorax, pneumomediastinum, very, very rare complications. Accidental displacement of the tube. You were doing it, and the patient woke up or something like that. Tube can come out sometimes, and then sometimes cardiac or respiratory decompensation can occur. Then late complications are tracheal ulceration, tracheocutaneous fistula, granulation tissue, tracheal stenosis, scar formation. They do occur, but not very common nowadays, because we use this cough, which is high volume, low pressure cough. Next slide. As far as the post-operative care is concerned, you should do a wound and dressing care. You should daily examine the stoma, keep the wound clean. Next slide. Dressing, you should change every day. And if you are using the inner cannula, you should at least change 2 to 3 times a day. Ideally, it is said, but if patient has no secretions, even once a day is enough. Next slide. You must humidify, whether you use a heated humidifier or use a HME, you must use an humidifier. If person is not even in oxygen, nowadays there is a thermovent available, a small, which you can put on a tracheostomy, which will help the humidification of the airways. Next slide. Now the suture which you had put in, you remove at the time of the first tube change, or approximately 5 to 7 days post insertion. And you must observe the suture site for sign of infection and then treat accordingly. Next slide. This I have already told. Next slide. Then cuff pressure, you should keep 20 to 30 centimeter. and should not exceed 32 centimeter, because it can then result in the necrosis of the wall and predisposes to the stenosis. Some people say the palpation of the balloon, but that is not enough. You should have a pressure measurement, and you should measure at least once a day or twice a day. Next slide. Changing a tracheostomy tube. Sometimes within 5 days, the tube has come out, has got blocked. This is very tricky. And, you should be very careful in changing, because sometimes there is a tracheostomy and resident would say, I will change it. And he will go into the false track and cause problems. What my principle is, I allow them to do it once. And if they are able to change it, I allow them to, but if they are not, I just tell them, do an endotracheal intubation. I'll come tomorrow morning and do it. But if it is during daytime, expert person should do it, and you should not get panicky if it is happening like that. The best thing is to intubate that patient and then do with control. The airways is controlled. The patient is not unstable. That way you can do it. After 5 to 7 days, it is not a problem. And around 7 days for percutaneous tracheostomy, because the track is formed and anybody could be able to change it. But as far as the elective changes is concerned, normally tracheostomy tube doesn't require change if it is patent. And even up to 3 to 4 weeks, the patient on a prolonged tracheostomy tube, you can keep them. Next slide. Next slide. As far as the feeding is concerned, people are very keen once the patient is on tracheostomy, not on a ventilator, to feed them. When you want to feed them, there should be adequate cough and swallowing reflex, adequate oral motor strength, significant respiratory reserve. Patient is dyspneic, you can't feed that, he will aspirate. Assess the swallowing functions and then you feed it, and it should have a proper consistency when you feed these patients. Always remember, there is no tracheostomy which is 100% aspiration proof. Minimal aspiration can occur. So you should be very sure that patient has an adequate cough reflex when you allow them to be fed. And next slide. When to remove? When patient is medically stable, the primary indication has resolved, spontaneous breathing, effective cough reflex, minimal pulmonary secretion, oxygen therapy is less, he is successfully tolerating cough deflations, adequate nutritional intake, then this is the time you should remove the tracheostomy tube. Next slide. As far as the training and competency is concerned, minimum of 20 you should have before you can independently do is, and it is advisable to practice on an animal model. And just to conclude, sorry, because my slides were separate and I was speaking separately. So there are two methods of tracheostomy, surgical and a percutaneous tracheostomy. Percutaneous tracheostomy offers many benefits and is a good alternative. Timing of tracheostomy does not have a clear association with better outcome. So it is okay if you do a 10 or 12 or 14 in terms of patient comfort and nursing care. And percutaneous tracheostomy does not have a clear association with increased incidence of nosocomial pneumonia, because previously people used to say, so there is no association. And I think tracheostomy care, knowledge and skill are important for both doctor and nurses so that the complications don't occur. Thank you very much.
Thank you, Dr. Chawla, for a very simple and illustrated talk. You've actually made a very complex topic very simple today to all of us. Actually, I'd like to share with you here that this topic of tracheostomy has basically been chosen on the popular demand of the residents, who felt that there is no single chapter or no single article which describes all the aspects of tracheostomy at one go. So I think the whole concept of today's webinar is around that, and I think you've made our job very, very easy, to carry on the discussions further. I think some of it may just be a repetition, but I always call it more as a reiteration than repetition, because it's an opportunity to, just have a recap of everything altogether. So as I introduced in the beginning itself, we have a very illustrious, very well accomplished, well experienced, and academically oriented panel this evening, in which we have Dr. Tampi with us, Dr. Unnati, Dr. Abha, and Dr. Neel, Of course, Dr. Chawla is there with us for the next hour or so. So if any one of you has any questions, you can all type it in the chat box and send them to me, and I'll take up your questions. In the meantime, let me start the ball rolling with asking Dr. Tampi the first question. That Dr. Tampi, apart from the indications that Dr. Chawla just mentioned, do you think there are any other indications also where you may want to use tracheostomy? Dr. Tampi, you're muted, sir.
Thank you very much,
Can you unmute?
Dr. Vivek?
Can I request all the panelists to unmute themselves, because every time this will be a problem. You just don't realize sometimes that you're muted. G. Dr. Tampi.
Yeah. So thank you, Dr. Vivek. That was a fantastic lecture on tracheostomy by Dr. Chawla. And in the indications of tracheostomy, I think I would like to classify them as emergency indications and elective indications. Emergency indications, as he mentioned, we don't see very commonly, but yes, we need to be prepared. And there is, of course, acute upper airway obstruction with a failure of the endotracheal intubation, as would happen in probably angioedema, Ludwig's edema, angina, or a foreign body, or an acute infection, or even an anaphylaxis, where intubation would probably fail in these patients. The second indication is a post-cricothyrotomy. Now, once the airway is established, the cricothyrotomy should be converted to a tracheostomy. The third is a penetrating laryngeal trauma, which can, completely disorganize the architecture, and therefore you need to establish a route for the airway. And the last indication for emergency is, facial fractures like Lee-Fort class 3 fractures, where there is complete disruption of the midface, nasofrontal bones, the bilateral zygomatous sutures are disturbed, and arch fractures. So here there needs to be an emergency tracheostomy established. Now, more commonly, which we do is the elective tracheostomy, and as Dr. Chawla mentioned, the commonest indication is those for prolonged ventilator dependence. And normally we consider 5 to 7 days, or with the low pressure cuff tubes now, and keeping the pressure below 25 centimeters or 30 centimeters, as he mentioned, we avoid, necrosis of the trachea. The second indication would be a prophylactic tracheostomy prior to head and neck cancer treatment, and which is normally established by the oncosurgeons. The third indication is an obstructive sleep apnea, which is completely refractory to the common treatment that we deliver on these patients. Then chronic aspiration, particularly in patients with neuromuscular diseases such as amyotrophic lateral sclerosis, etc., where it is difficult to control the aspiration. So therefore, we need to establish tracheostomy in these patients. And of course, subaortic stenosis and severe vocal cord paralysis, either an adductor or abductor. All these form elective indications for establishing a tracheostomy.
Absolutely right. I think we've done tracheostomy for our Parkinson's patients, those with PSP, very often, basically to protect their upper airways. Otherwise, they keep having their recurrent aspiration, recurrent pneumonias, landing up in the ICUs. People are not very fond of getting a PEG done timely. They keep avoiding that as much as possible. Tracheostomy seems to overcome all these issues and protects the lives of such patients at least. Dr. Unnati, what are the different types of tracheostomy that you come across, the different types of tubes that you use in your daily practice?
Yes, thank you, sir. Thank you, Chawla, sir, for your really great lucid lecture. Sir has already covered it. The tracheostomy, the different types are surgical and the percutaneous tracheostomy. As sir has also mentioned that the various tubes, the commonly used ones are the cuff tubes and the uncuffed tubes. Then we have certain tubes like in patients with prolonged ventilation, we have the fenestrated tubes. Tubes are also classified on the basis of the cannula. So you have a single cannula, lumen cannula, or a double lumen cannula. And tubes can be, subsequently classified as, some tubes with glottic suction, or tubes which have, adjustable flanges, tubes which Sir has shown, angled tubes or straight tubes.
Right. So, Dr. Abha, the day the patient gets intubated, ventilated, is it the first day itself that you start thinking about tracheostomy, or you give them time? Like, what is your usual practice? What do you think is the optimal time of tracheostomizing a patient? 5 days, 10 days, 15 days, or is there no time? It's just a gut feeling that, okay, we waited long enough. Now let's just go ahead and do a tracheostomy.
Hello, sir. Thank you so much. Thank you, Dr. Chawla, for such a lucid lecture, because now actually we all know everything. We are only on the reiteration. So like Dr. Chawla said, there is nothing like an optimal timing, which is described in the literature. But yes, whenever we have a patient who we've ventilated, the first thing we should think about is, am I anticipating prolonged ventilation? It's very simple for neurological patients, because we know that with their neurological problem, they are going to require an airway protection. So doing an early tracheostomy is actually pretty much in the right place for them. When we talk about patients with respiratory failure, we must analyze. In our practice, we usually after 7 days is when we start thinking. So if the patient is not getting weaned, or if I'm anticipating a difficult weaning for the patient, for example, I have a very chronic, severe COPD patient with an associated cardiac problem, where I don't want to have that threat of weaning and getting the patient into more trouble, that's when we would start thinking. But yes, there is no hurry. We can optimize the patient. And by 10th day or so, between 7 to 10 days, I think is not a bad time, but without rushing into it. So we are looking at work of breathing of the patient. We are looking at if your patient has too much of pulmonary secretions, which are going to get benefited with a tracheostomy. If our patient is requiring too much of a sedation. So the main motive of early tracheostomy in these patients, which I would say multiple papers defined it differently, but like how Sir said, that between 10 to 14 days is now what is taken as early tracheostomy. Anything beyond 14 days is late tracheostomy. So early tracheostomy has shown us benefits in short-term mortality. It definitely reduces the duration on mechanical ventilation, thereby reduces the complications of mechanical ventilation. Uh, it will reduce the dead space. So the chances of having a weaning failure reduces automatically for my patient with respiratory failure. So yes, somewhere after 7 days, we start thinking, and whenever the time is right, patient is well optimized, we go in for tracheostomy only after that, with a full discussion and counseling of the patients with it.
Right. So I guess what you actually correctly said is, if there is somebody with a neurological problem, whether it's a CNS or a peripheral, then you're not going for an tracheostomy, because the situation is going to require prolonged ventilation. Whereas on the other hand, when it's a respiratory problem, a pneumonia or something, yeah, yes, then also if you feel that you're requiring, I mean, you're hoping the patient would be on ventilator for say about 20 days or so, then it's better to tracheostomize as early as possible, or else delay it if you think there's a fairly good chance of patient getting extubated. So, Dr. Neel, coming on to you, that what are the pre-procedure evaluation that you would do in these patients? Is there any set protocol that you follow, or is there, again, arbitrary things that you would follow in this situation?
Thank you, sir, for the question. Thank you, Dr. Rajesh Chawla, sir, for a lucid presentation on the techniques, indication, and the experience with tracheostomy. So the question here is regarding pre-procedure assessment. So normally, whenever if we decide on a patient that this patient is posted for a tracheostomy, number one, we've discussed with the indication. What is the indication has to be clear. The risk-benefit ratio of the procedure. The benefit should definitely outweigh the risks of the procedure. The technique that we choose, that in such a case, whether it is an elective procedure or an emergency procedure. So whether we are going for a surgical technique or we are going for a percutaneous technique. So based on the technique also, the preparations may slightly differ. So number one, suppose we discuss regarding the patient, that what are the factors. So we will definitely look at the coagulation profile of the patient. Is there any bleeding diathesis? Is there any past history of any bleeding problems? Is the patient on any blood thinners? As Dr. Chawla sir has shown us that clopidogrel, if the patient is on, then depending on the urgency of the situation, but however, if it is an elective procedure, we would wish to stop it. Based on the other, is the HIV, HbSAg, HCV of the patient sent? Ideally, we would want the patient to be either nil by mouth for 6 hours, or we would want that we'll aspirate the Riles tube if it's in place before the procedure. we make sure that we are prepared for any eventuality. So in the procedure, whenever we start off, we have to have preparation of an airway tray. A bronchoscope, if we have entirely discussed the procedure with the help of a fiber optic bronchoscope. So that is available or not? Is there any, if we are in the middle of the procedure and we face some problems, is there any alternative airway which is available in case we are stuck? So is the patient intubated or not in such a case in patients in the ICU? Otherwise, we need to have preparations for such scenarios. Besides that, the ventilatory parameters of the patient, hemodynamics, the overall medical history of the patient. Is the patient allergic to any specific medicines? So accordingly, we have to be sure that the prior medical history is properly taken and it does not affect the procedure or the outcome. Whenever we plan the procedure, also the neck. So like I said, if we are going for a percutaneous or a surgical, so if a patient has a very short neck and we are not able to even palpate the landmarks, so such case again, we would prefer to go for a surgical, a patient who's very morbid, obese. So these are all cases where this assessment is also important. The risk of aspiration of the patient. So whenever we are planning for a tracheostomy, is the patient at a higher risk? Is he a neurologic patient? Is he at a higher risk of aspiration post-procedure? So that needs to be identified, especially if we are going for a surgical procedure. There we will be using some form of the anesthesia. So the assessment is important in such cases. So these are some parameters, primarily host parameters, preparation to emergency, and a written informed consent is also very important, where we explain the patient the risk, benefit, as well as the chances and possible complications during the procedure. These would be some things which I would look at before for pre-operative assessment.
Right. Dr. Tampi, theoretically, I understand that there are no absolute contraindications to a tracheostomy, except for probably a local cellulitis or a local infection. In all other situations, you can do a tracheostomy. But who, in your opinion, would be the high risk group of patients, where you need to be extra careful? And what are the points to be considered in certain specific situations?
Yeah, that is a challenging problem. Who are these high risk patients? Most of these patients we know are critically ill. They are probably have been on a ventilator, and they must be having some kind of coagulopathy. And most often, they may even be on drugs like clopidogrel and ecosprin, etc. So these need to be assessed, stopped before we plan a patient's platelet. May even have very low platelet counts, thrombocytopenia, which is severe. And one should not attempt a surgical procedure when the counts are low for obvious reasons. So therefore, all this coagulopathy, the drug stoppage, and thrombocytopenia need to be corrected prior to planning the surgical procedure. The second high-risk group is probably those with aberrant, vessels. So there, I think we can take the help of the ultrasound, which Dr. Rajesh Chawla had mentioned, and try to identify if there are any bridging anterior jugular vein which are running in front of the trachea, or rarely a thyroidema artery, which, if not identified and ligated, can often retract and be a source of continuous bleed in these patients. Now, these are all the risks for the patient. But what about the risk of the operating team? In situations where there is aerosolization of respiratory secretions forms a risk. For example, tuberculosis, or as we recently had, the COVID-19 pandemic. In such situations, specialized, personal protective equipment needs to be used by all the team members, and preferably the procedure should be performed in a negative pressure room. These are some of the high risk and how to tackle these situations.
Yeah, very important. I think it's very important to protect ourselves also when we're doing an invasive procedure like this, which is likely to liberate a lot of secretions and aerosols into the atmosphere. So, Dr. Unnati, coming back to the same question of early versus late tracheostomy, who do you think really would benefit the most from an early tracheostomy?
So as we've discussed, sir, in emergency situations when you cannot intubate is where you would obviously do an early tracheostomy. So whether these are the cases which would obviously not come to us, but to the trauma surgeons, you have a head and neck cancer, you have an upper airway obstruction where it is not possible to intubate. This is where in emergency cases we would need an early tracheostomy. Classically, our patients, as Dr. Abha has also described, if I have a patient who will require prolonged mechanical ventilation, and I contemplate that would require prolonged mechanical ventilation, is a patient where probably I will consider early tracheostomy. So if I have a COPD with cor pulmonale, with say other issues like cardiac issues, I have a patient of COPD with cor pulmonale with say an obstructive sleep apnea, and yes, neurological patients are another patient. If I have a patient of COPD with Parkinson's disease or some neuromuscular incoordination are probably a few group of patients where we will contemplate probably a prolonged airway protection or a prolonged tracheostomy to be, prolonged mechanical ventilation or a prolonged airway to be in place. And there is where probably I will consider an early tracheostomy.
What about somebody with a cognitive dysfunction, who's not able to cooperate
Yes.
with instruction?
Correct. So who is prone to the risk of aspirations, and all these patients also probably, where we contemplate that there is a problem with handling the secretions or there is going to be a problem with handling the cough, is probably we contemplate early tracheostomies.
Right. Because, there are times when the patients are totally disoriented, psychotic, are not even able to cooperate with the pressure support ventilation. They're not able to understand what you're trying to communicate with them. So I think that would also be a situation where we must consider early tracheostomy so that would help us in weaning the patient off. The message here that I want to give everybody is that don't be apprehensive about tracheostomy. Tracheostomy is a reversible procedure. You do it today, even if tomorrow you feel that the patient is all right, you can yank it out. It doesn't matter. But keep it in mind. In fact, the day the patient gets ventilated, you should start preparing and see, whether it's 7th day, 8th day, 10th day. If you're expecting a prolonged ventilation, then you might as well do it early than late. So, Dr. Abha, of course, we know very well that there are two types of techniques that we use, percutaneous and surgical tracheostomy. So, how would you really weigh the two techniques and how do you differentiate between them?
So, percutaneous tracheostomy and surgical tracheostomy, I'll start with surgical tracheostomy. So, it involves dissection of pretracheal tissue and insertion of our tracheal cannula when I'm seeing the trachea right in front of me. Vis-a-vis, when we talk about a percutaneous tracheostomy, it's a blind procedure. So, this involves the introduction of a tracheal cannula by means of blunt dissection of the pretracheal tissue. And then we have our Seldinger's technique as a guide, where we, like Dr. Chawla explained very well, that we have a guide wire, then we have serial dilators. So we are going to ensure that I'm in the airway and then sort of keep on dilating the passage and put the tracheostomy tube inside. So it is a blind procedure. Now, comparing both of them, surgical tracheostomy is done in operation theatre. So we need to schedule a time slot for it. It is a longer procedure as compared to our percutaneous tracheostomy, which is done at bedside. Relatively lesser duration if you have a good learning curve with it. Cost-wise, again, percutaneous tracheostomy turns around to be, of course, less costlier as compared to the OT-driven surgical tracheostomies. But there are some instances where we should not go in for the blind procedure. Like, for example, if I know that I have a cervical instability, if I have a trauma patient, if I have a patient with very short neck where I'm not able to visualize the anatomical structures very well. Now, these are the situations, or I'm not able to extend the cervical, I'm not able to get the cervical extension. So these are the candidates where we should not go in for a percutaneous tracheostomy. Rather, wheel them in the OT, not take any risk, and get an open tracheostomy. That's always preferable. The only thing we need to understand that percutaneous tracheostomy requires a learning curve. So there are certain number of procedures which we have to do to be able to confidently manage this procedure in the bedside domain, and it is definitely now much more acceptable. There are some now, like Dr. Chawla said, we can do an ultrasound and we can actually see the vascular structures to the anterior part of the trachea. So the only problem or the stress which happens in a blind procedure, am I damaging a vascular structure? That's one of the major issues with that. So even that can be taken care of.
Right. So basically, if we were to choose between the two, for somebody who has a short neck, stout neck, obese patient, unable to extend the neck, probably you'll go in for an open surgical tracheostomy. In all others, PCT would fit in very well. So, Dr. Neel, now PCT also has, different different techniques and different kits that are available. I mean, I have only been using that metallic dilator where I find that the simplest one, but I don't know what your experience is. How would you want to describe that?
So, in the various techniques that are available for percutaneous technique for the tracheostomy, so basically one method which Chawla sir has described in his slides is using a bronchoscope, where we are visualizing with the bronchoscope and we have a single dilator. So we have Greek's technique or the Greek's forceps, which you are saying. There is a forceps between which we can, with in that step only, we can push in the guide wire between the forceps, and it helps with the dilation of the tract, the forceps itself. But nowadays we have within the percutaneous tracheostomy sets only dilators, which are an option. We have with or without forceps. Even the Portex percutaneous kits we have with or without forceps both. So in the one with the single dilator, so normally if we do it under bronchoscopy guidance, or in cases where it is done without. There are cases in the ICU setting where it is the bronchoscope may not be there, and still it can be, or it is done without the bronchoscopy guidance also. Ideally, definitely under vision is the best part. But in such cases, normally we make sure that the patient, first of all, we've done the preoperative assessment, and we make sure that the patient's position, the neck is hyperextended, and we've marked the landmarks properly, especially the thyroid and the cricoid cartilage. And below the cricoid cartilage, in the second or the third, between the tracheal rings, we make sure that the point we've anesthetized, for cleaned and painted and draped first, ensure that there is proper staff, one person at the head end, to, if the patient is already intubated, then we need to pull the tube early upwards towards the vocal cord after deflating, and then inflate it again, and make sure that one person is also there with us as the nursing staff. So in case we need any additional drugs, the patient has to be sedated, if needed, even paralyzed with a neuromuscular blocking agent. So we put in a local anesthetic drug there, lignocaine, which we instill transtracheally. We confirm it is in the trachea. We pull the air, that there are air bubbles coming. So the position is confirmed that it is in the trachea. After that, we give a small horizontal incision around 1 to 1.5 centimeters. And gradually we introduce with an introducer needle, and with that we introduce the guide wire within it. First, we have a shorter, smaller dilator, which we push over the guide wire and dilate the tract first. Then we have the single stage curved dilator, which Dr. Chawla sir had showed in the images, which we can push. But throughout this position, whenever even we are putting the guide wire, we have to ensure that the needle is facing downwards, so that whenever it should not pierce the posterior end of the trachea, and the wire, when it goes down, it should not be going falsely up. It should go downwards, so that there is no false lumen and the root is appropriate. So after we've dilated with the curved single stage dilator, we make sure even when we put in that dilator, sometimes even we may need to increase our incision site. So accordingly, we have to troubleshoot during the procedure if at all that is needed. And then we remove the dilator and put in the tracheostomy tube, inflate it, put the proper ties. We can check it by auscultation or as by visualizing with the bronchoscope. Tidal volumes are appropriate. If we have an end-tidal CO2 monitor, we can also check with that the position of the tube is appropriate. And after that, we can gradually withdraw the endotracheal tube once the patient's ventilation is set up on the tracheostomy. So the two techniques here, like we have the single dilator, we had the Greek's forceps technique, and definitely now with good technology and with the availability of the bronchoscope, that is the safest modality where this procedure can be done with proper visualization of the bronchoscope.
Right. So, Dr. Chawla, when we started doing our tracheostomies, at that time, we probably started without the bronchoscope for some reason. I guess using bronchoscope for tracheostomy became more fashionable much later on. So, I want to ask you that, is there a lot of data to support its use, or can one start doing a tracheostomy even if they don't have an access to bronchoscope?
We've in our unit, we've done more than 850 percutaneous tracheostomy. Initially, I was doing the Crick's technique and were using the forceps. And at that time, we were not using the bronchoscope. And there were, I remember, cases with little extra bleed in some of the patients. But, then we started using bronchoscopy to guide it. But, the most of the consultant in our units are very experienced, and we can do it without and with also. But we always keep the bronchoscope by the side of the bed, because many a times you are not sure. You need to be sure that you are in the trachea. But if you are not in the trachea and if you're not sure, you must do bronchoscopy guidance. If people are listening, I would suggest, if it is available, please do with bronchoscopy guidance, because for a learner, because you are very sure where you are, and it doesn't cause you a lot of palpitation, because when you are blind, you are always scared. You may not touch the posterior wall, or you've crossed the posterior wall. So bronchoscopy is a very safe. Once you start doing it, it is such a simple procedure that you go at the end of the endotracheal tube, come up, identify the subglottic area, and the rest of the procedure you can do as it is explained. And there are various ways to do it, whether you do a Crick's technique or a multiple dilator or a single dilator. But after we've started using this single dilator, it doesn't take more than 5 or 7 minutes, to not even 5 minutes, to do a tracheostomy, in percutaneous tracheostomy, because it is that fast a procedure. And of course, with less of bleeding, less complications with this technique. What is our experience? But the downside, it is very expensive. The single dilator, this set is expensive. So I think whichever you are comfortable with, whichever set your unit is comfortable with, but I would suggest that you do it bronchoscopy guidance. And now the ultrasound is there everywhere. If you're not using an ultrasound to guide it, at least you must do an ultrasound to mark the place where you are going to do, and also to rule out any vessels. Because now it is becoming more and more important for the procedure to be safe. When an ENT surgeon is doing, nobody bothers there is a bleeding. And when a pulmonologist does and a simple complication occurs, there's a lot of. So you need to be careful that this procedure should remain with the pulmonologist and in interventional intensivist as well. So one needs to be very, very careful and do a safe procedure. And I think initially you must do with bronchoscope. Of course, it can be done blindly. A lot of units are doing blindly, but I would suggest, there is a lot of literature to show the safety, appropriate position of the tracheostomy tube when you do under bronchoscopy guidance. So you should do it a bronchoscopy guidance. And that's why the endotracheal tube should be at least 7.5 to 8 millimeter, because the bronchoscope cannot pass if the endotracheal tube size is less than this. So sometimes what happens is the tube size is smaller. Then you change the tube and then probably do a procedure with the bronchoscope.
Yeah, so I agree with Dr. Chawla that, while a blind procedure gives you a huge adrenaline rush, as soon as the tracheostomy goes into its position, you pull out the trocar out of it and you feel that air coming out. There's so much of excitement that you've achieved something, but I think it's important to be safe with the patient. So if your endotracheal tube is a small size, probably you could use a pediatric bronchoscope for that purpose, but don't just use that as an excuse for not using the bronchoscope. Bronchoscope is always bronchoscope, ultrasound, guidance. They're all now aids that help us provide safety. I mean, the procedure in a very safe environment. Ultimately, safety of the patient is very, very important, that we need to remember always. So, Dr. Tampi, when you compare, PCT versus surgical tracheostomy, what do you think are the advantages and disadvantages of PCT in this situation?
Yeah, I think a lot has been spoken about the advantages and disadvantages in the comparison between the percutaneous tracheostomy, the new kid on the block. Advantages need to be, the percutaneous tracheostomy is more amenable to a bedside performance rather than taking the patient, avoiding transporting to the operating room or the OT of a potentially critically ill patient who's on a ventilator. So one needs to weigh these pros and cons. And besides, you do not need an ENT surgeon or a thoracic surgeon to do this procedure. And as you mentioned, it can be done by a interventional intensivist or a trained pulmonologist who can achieve this by the bedside in the ICU itself. Also, percutaneous tracheostomy is known to have much less blood loss as compared to a surgical tracheostomy, and there is definitely a lower infection rate from the various head-to-head comparison studies. Having said that, the disadvantages are, as mentioned recently by the previous speakers, Abha had mentioned, an obese, short neck person cannot be taken up for a percutaneous tracheostomy. Also, somebody with a cervical instability we should not attempt a PCT in such a patient. And also the need for a bronchoscope in these patients adds to the cost, and also the availability of two physicians at the same time to be there to do the PCT. Lastly, the devastating complications, though rare, which can be seen with a percutaneous tracheostomy are tracheal lacerations, which may be quite severe. After all, it's a blind procedure. Aortic injury and esophageal perforation, which are extremely unusual following a surgical open tracheostomy. These are rare, but have been reported in various studies.
But do you think there's any difference in the long-term outcomes, whether the tracheostomy was surgically done or percutaneous done?
Now, in the difference in the outcome, I would put it like this, that the amount of ICU days and the ventilator days would definitely be lesser with a percutaneous procedure. This is what some of the studies have shown. But as such, there is no broad difference between the two procedures, provided you select your patients correctly.
Right. So, Dr. Unnati, you've done the tracheostomy for your patient. Now, what are the instructions that you would want to give the nursing staff there about how to take care of the tracheostomy?
So taking care of the tracheostomy stoma or the dressing or the wound is very important, because we know that we will invite more trouble, more than, after the safety, it is the infections that we are worried about. So the first important thing could be probably the site, the gauze. Like in our institution, we use the cotton gauzes and the cotton ties. So I would, probably ask for checking the soakage of the gauzes, whether there is any blood staining, excessive blood oozing from these dressings immediately post tracheostomy, and on a daily basis, on every shift basis, to check for whether there are any, other than the blood, following that, whether there are any other secretions. We have patients who have pneumonias, who have ARDS, or who have respiratory infections, and there could be secretions which could be staining these dressings, and it is important to change these dressings. So checking the dressing at every shift, whether it is a 6-hourly or an 8-hourly shift, to change a soaked dressing or a visibly soaked dressing. Also, to assess for whether there is any problem with the cuffs. So we need to be sure that the cuffs are all inflated, especially when the sisters or the nurses are giving feeds to the patient, so that there is no risk of as such an aspiration. And yes, suctioning is something which is very, very, very important, and very often it is, and everybody says whose responsibility it is. So suctioning whenever there are any audible or visible secretions in the tube, suctioning whenever there is, a desaturation that is documented, suctioning whenever there is an increase in peak pressures noted, is what would be the care for the tube that I would tell the nursing staff to take.
Right. So, Abha, the tracheostomy has been done. You've instructed the nursing staff to, look after the dressing, the infection. Anything else that you feel could happen in the immediate post-tracheostomy period? Any kind of complication that you can anticipate?
Absolutely, sir. So we are handling airway. So definitely we must be anticipating the complications, because only then we can efficiently handle them timely. So there can be bleeding. A bit of a trickle bleed, like Dr. Chawla said, there can be a little stromal bleed which can happen. You've taken a neck. So that can be managed with Surgicel itself. We don't have to really but then we have to always closely keep monitoring that area, because a small bleed can turn into a torrential bleed also. So bleeding is one of the immediate complications which we should always be wary of. Again, if we have a bronchoscope next to us, it's always helpful because you can go and you can check everything is okay or you're seeing any spurt around. You can see locally around the stomal area also. If there is too much of a trickle which is going inside the tracheobronchial tree down, then even that has to be tackled with a cold saline. So we should have that handy. Then you can have a structural damage to the trachea, like how Dr. Tampi said that we can actually damage the trachea with a rent over there. So doing these procedures in the daytime where you have maximum help as a wider team model always works best. You should have an ENT person around handy. You should have a surgeon around handy. If in case you need, then doing these procedures, they are elective procedures. Doing them in the morning hours is the best thing to do. So tracheal rent happened, and if we have subacute emphysema, we have pneumothorax happening, we have to immediately intervene by putting an intercostal drain for the patient. Secure the airway. That is the first and foremost rule with any complication. Then you can have failure of procedure itself. So when you are doing it in an open surgical tracheostomy, everything is right in front of your eyes. So these chances are lesser. But when we do a percute tracheostomy, which is a blind procedure, every step is important. So if you feel that you have not actually aspirated the air, stay over there only. Do not proceed to get into more and more problems over there, because then you are going to form a false passage. You're going to hit structures around. Unnecessary complications can happen. Aspiration event. Prepare your patient very well, like how Dr. Neel said. So you should keep the patient empty stomach. Aspirate the RT if there is an RT in place. Give an anti-emetic agent if patient has some issues ongoing or if the fasting duration is not too much. But these are essentially elective procedures. So preparing the procedure well always helps. Sedate your patient very well. If he is woken up right in the middle of the procedure, he can actually have an aspiration event, even if you've kept a good NBM for the patient. Then you can have air embolism, not a very common thing, but yes, we should be mindful if there is a sudden drop in the parameters, the oxygen is dropping, embolism must always be suspected. You can lose the airway. Anytime where you are doing a procedure like tracheostomy and you lose the airway, just secure the airway with an endotracheal tube, let the patient stabilize, and again, you can re-attempt the procedure with much more of a team around. You can have decompensation respiratory parameters. You can have worsening hypoxia, worsening hypercarbia. We may even lose the patient. So all these things can be actually prevented, managed well if you have a good team around, more hands to help. If you have people around to have an intervention if needed, you have to wheel the patient to the surgical areas if in case there is a trauma to the trachea. All these things have to be preempted and worked upon.
Yeah, I think I would agree fully with you that you made a very valid point that when you're working in an ICU, you have to preempt the things and take the appropriate measures rather than waiting for the things to happen and then doing something. It's exactly like sending a blood culture and then waiting for 48 to 72 hours for the report to come in and then change the antibiotic. You have to be preemptive in in anticipating what you expect in that blood culture report and making the changes beforehand itself. Of course, you could tweak it subsequently once the culture report is available. But the art of ICU is preempting things and managing them. So, Neel, coming on to you, that if your patient is supposing on room air and a tracheostomy has been placed, then how often would you suggest changing the tracheostomy, or is there no need to change the tracheostomy at all?
Sir, normally for changing the tracheostomy, if we are doing it by the percutaneous or the surgical route, around in the first 1 month post the procedure, we do advise to change the tracheostomy tube. In percutaneous, sometimes even after a period of 2 to 3 weeks. Now, precautions besides this, what happens is that in a lot of time when the patient is on room air, over a period of time, the patient is given a speech valve. So I'll give you an example. Recently, we had a very young patient, around 30-year-old male, young, thin, lean fellow. He had a recurrent ARDS, prolonged ventilation, went on to a tracheostomy tube. He was using a speech valve regularly because it gave him comfort. Like when he applied, even initially with oxygen support, gradually even without, he's been using. But he had that one problem that he even started using that valve and keeping it at night. So a lot of time what happens is such valves, whenever we are using for any patients, even though they are on room air, it is important that they are removed at night during sleeping, especially if you are using any form of a valve with the tracheostomy tube, suction equipment at home, and the other antisepsis, the aseptic precautions for using the suction catheter around the stoma site. That also needs to be taken appropriate care. And once the only thing against early changing of tracheostomy tubes is that we need to make sure that the track is mature and has formed appropriately before we try to remove and try to put in the new tube, because we don't want the risk of creating any new false passage or undue bleeding or any other risks earlier. So unless the tube is recurrently blocked, and even now we have suction, we have bronchoscopy, we have other modes by which we can remove the secretions or clots or any other problems which might occur earlier. So at least the timeline, which I think Dr. Chawla sir's slides also mentioned, was around 1 month is the time where we definitely think of changing. And for room air patients, this precautions related to the valve and the suction equipment as well as asepsis is important.
Right. So I think since we're running out of time, I'll just quickly go through the various complications and request you all to, just keep it brief as possible. So Dr. Chawla, coming on to you, sir, that what about the tracheocutaneous fistula? How often do you see it and how do you really manage it?
Tracheocutaneous fistula is when, if you have taken out the tube, the tracheostomy tube, and the hole is still persisting. That is what he's talking about, is a tracheocutaneous fistula, where the tracheostomy tube is attached to the skin. And this problem does occur not too many times. I would remember that at the number I mentioned, we must have seen 15-20 times. And in the literature, it is reported up to 11% people can have. What happens is, if you are not keeping the stroma, if you're keeping the stroma contaminated, there is a granulation tissue, what happens is the skin also grows inside. And once you've taken out the tube and you put a gauze, this doesn't close. Now, if you give it time, most of the times it will close. And what you do is you put a Tegaderm so that this area is totally closed, because if there is too much of air coming, it never closes. So put a Tegaderm there. If it is still not closing and few days have passed, then you can ask your ENT colleagues. If the 10-15 days, sometimes patient comes in the OPD and still the air is leaking from the tracheostomy tube. And they do a procedure in the layer procedure. So you need not just stitch, because just putting a stitch never helps. So what they do is they do a layered stitching. They stitch the trachea, then the area, the subcutaneous tissue above it, and then the skin. Then only it closes. But it's very rare. And most of the time, once you've taken out, most of the people, this will close. The stoma closes about 4 to 5 days. In certain people, it may take. But if it is very long, then you should take a surgical help. And I don't think we should indulge in doing all this stitching.
Dr. Tampi, a few words about tracheoesophageal fistula.
Yeah, the incidence is quite a rare complication. I think rarer than the tracheocutaneous, because hardly about less than 5% in tracheostomies that we see tracheoesophageal fistula. The risk factors are the overinflation of the cupped endotracheal tube. This has been discussed ad nauseum, and we need to keep the pressures below 20 centimeters of water. And so using low pressure cuffs and monitoring the cuff pressure is mandatory and all important here. The other risk factor is the presence of an indwelling nasogastric tube for feeding, in addition to the rigid tracheostomy tube. So this increases the risk. So in such patients, we should always suggest an alternative route of feeding, such as a gastrostomy tube or a PEG tube may be advised in these patients. And they usually present with recurrent bronchopulmonary suppurations or tracheobronchial contamination with food and gastric contents, or simply recurrent and severe pneumonias. So the length of these fistulas is usually about 1 to 4 centimeters, and we need to manage it with resection of the fistula, primary esophageal closure, primary anastomosis of the trachea, and intraposition of viable muscle flap to ensure good healing and no recurrence of the fistula.
Right. Dr. Abha, what about tracheoinnominate artery fistula? A rare complication though.
It's a rare but life-threatening complication after tracheostomy, I would say. Only 0.1 to 1% is documented in the literature so far, but it's an acquired fistula, typically seen from 3rd day to 6 weeks of doing the tracheostomy, where there is a formation of fistula between the brachiocephalic trunk and the trachea, which is induced by the tracheostomy cannula. by the mechanical pressure. So typically there is an ulcer formation, there's focal necrosis happening and loss of cartilage. That's how the fistula is formed. The most important thing is diagnosing it timely. So we see that 30% of patients actually have sentinel events, like they'll have small trickle hemoptysis, they can have bleeding coming from the tracheal lumen. So, and then eventually you will see a pulsating TT cannula, like the tracheostomy site, you will see a pulsations very clearly. And this is also one of the way you can anticipate that there is something like that happening inside. And then you have this one massive hemorrhage happening. Because of this hemorrhage, the problem happens that there's a loss of airway control and you have a simultaneous hemorrhagic shock, and both need to be taken care of immediately. Coming to the diagnostic part, so usually CT angio is not enough to diagnose. Bronchoscopy works very well. You put in a scope, if you see a blood spurting from the anterior wall of trachea, you know that this is a rupture coming from the spurt coming from the innominate artery flow. You can also do CT angio where you'll see the blush coming from the innominate artery. Talking about the management, so I think the most important part in this particular complication is the immediate care of airway, breathing and circulation. You first have to try and control the bleeding because that's going to obstruct your airway. So many times increasing the cuff pressure a little more really helps to sort of have a tamponade effect a little bit, and then wheel the patient, call for help immediately, wheel the patient to the OT. The conventional ways have been the open surgical procedures where you have a sternotomy done. You open the area, you handle ligate and divide the brachiocephalic artery. And then now we also have these endovascular procedure where you can have a graft which can be placed in the trachea like a muscle flap. And you can have a vascular graft which is placed on the arterial part of fistula. Risk factors have to be known. If we do a tracheostomy which is very low, below the third cartilage, then we are very much nearing to the innominate artery, which crosses the trachea somewhere around the sixth ring. So the chances of the cuff with higher pressure to damage and create a focal necrosis is much higher. Or if your patient is, when you're using a very high cuff pressures, again, you are allowing for the pressure necrosis and these kind of complications are invited. And thirdly, steroids. So if you have a prolonged steroid, even that can lead to these kind of problems more. If you have tracheitis, which is there, if there is a stomal infection which has gone inside deeper, even that can lead to more and more inflammation and focal necrosis. So even if we operate these patients, their mortality rate is still very high, more than 50%. So this is something which we must know about.
Right. Dr. Unnati, tell us something about the post-tracheostomy tracheal stenosis.
So the post-intubation or the post-tracheostomy tracheal stenosis is usually the stenosis of the subglottic area. Classically, I would have a patient on a tracheostomy, history of tracheostomy, presenting to me with stridor and a PFT showing a fixed upper airway obstruction or a box loop. So what are the factors? Yes, any prolonged mechanical ventilation which is required, a tracheostomy tube to be in place for a prolonged duration, infections, any trauma associated with the tracheostomy procedures, and yes, improper tube sizes which will cause a pressure necrosis in the tracheal wall are known to cause post-tracheostomy tracheal stenosis. How could we prevent post-tracheostomy tracheal stenosis? Yes, we could be carefully using tube cuffs which have high volume, low pressures. We could do intermittent deflations carefully. And yes, as soon as possible, when the tracheostomy is not needed, we could decannulate the patient.
Right. So, Dr. Tampi, the patient has a tracheostomy in place. The mouth is open. I mean, mouth can be used by the patient. So, when do you start feeding your patients when the tracheostomy has been, after the tracheostomy, I mean?
Yeah, I think the biggest danger is to prevent aspiration. So the first thing that I would do is to raise the head into the bed and keep it elevated to prevent aspiration, number one. Number two, as was discussed earlier, there should be a proper evaluation of swallowing, preferably by a swallowing therapist or a speech therapist who can come in and check that the swallowing is being done properly and the patient is conscious enough for that purpose. It is preferable to start with the thicker fluids, and this should be started. It can be started immediately after the procedure is completed and the patient is conscious, there is no bleeding, no complication, the head end is elevated, your swallowing mechanism is intact, then it's better to start with thicker fluids like soup or blended drinks, and they are safer. And once the patient gets used to the tracheostomy tube, thinner fluids like water, etc., can be given, and gradually soft semi-solid diet can be introduced. And once the patient is completely swallowing without aspiration, full diet can be given orally.
And this is irrespective whether the patient is on the ventilator or off the ventilator.
No, if the patient is, if the patient is on ventilator, usually there's a nasogastric tube feeding or a PEG tube or something in place. Okay, so if that patient, I mean, that's what I meant, that if the patient is not conscious enough or not capable of swallowing or not, cooperative, then we will not be able to feed the patient orally. Only when his swallowing mechanisms have been evaluated and you know that all these are in place, then only I would start oral feeds. Otherwise, I would continue with the nasogastric feeds or a PEG feeds till such time the patient is better and can take things orally.
Right. So, Dr. Unnati, one thing that happens when you explain to the family or the patient that, we're going to do a tracheostomy, their first response is, will our patient be able to speak, Dr. Saab, after this? So, what about speaking valves? I think they've kind of revolutionized now the use of tracheostomy and the ability of the patient to speak immediately after the tracheostomy itself. So, when do you start using them and how really?
So a speaking valve is usually used for patients where we contemplate that we are going to keep the tracheostomy for a long time and the patient wishes to, yes, speech is an important, sense to be used. So the most important thing is that when we use a valve, we will have to use an uncuffed tube or we'll have to keep the cuff deflated. So the patient should be able to take care of his secretions and there should not be any risk of aspirations. These are two important things wherein if the patient is able to take care of the secretions, we are able to take care of the secretions, and patient is not at risk of aspiration, is when probably I will be able to deflate the tube or use an uncuffed tube, and when a speaking valve could be used.
Right. So, Dr. Abha, nowadays the ECMO is also becoming very popular now. Most centers are using ECMO. So, in a patient who's on ECMO, when would you like to time your tracheostomy? Early or again wait till the 7th or the 10th day still?
Sir, in ECMO, these patients are VV ECMO. These patients are actually already having a severe pulmonary dysfunction, and usually they are on ventilation for a long time. So early tracheostomy is actually better in this profile of patient. And between the surgical and percutaneous is actually preferable over surgical tracheostomy in ECMO patients. So the timing definitely, this is a lot where early tracheostomy has data that it is much better for the mortality benefit of the patient also, and it should be opted for. Again, ECMO patients, the only red flag we have is bleeding because they are on anticoagulation. So the point to consider for these patients would be that be mindful that there can be bleeding. It is known, there is literature. So counseling of patients' relatives is extremely important before you touch the patient. We can try and minimize the bleeding by, patients are on heparin, so the APTT, PTT should also be monitored. In the normal range only, we should go in for tracheostomy. And perioperatively, we have to stop the anticoagulation. But within 6 hours of tracheostomy, once the patient is stable, there is no active bleed, which we see from the tracheostomy stoma, we should restart the anticoagulation. Still, there have been reports within 48 hours from tracheostomy that there has been issues with the circuit blockage because of the clot formation. So that is something which we have to accept, prime, discuss, and then go in.
Perfect. So, Dr. Chawla, from ECMO now to NIV. NIV, of course, has been our mainstay now for years for managing all these patients with type 2 respiratory failure. Do you see any situation where you would want to do a direct PCT of in a patient who's on NIV in the ICU?
I would not do it. After doing, I feel, as I said all through, there are case series people have done on NIV and did this, and I think it is not needed. When you can intubate, you secure the airways. Nowadays it is very important to be safe. So if you are planning to do a tracheostomy, you are anyway intervening into the airways. So better put a endotracheal tube and do under the controlled situations. I have done without intubating the percutaneous tracheostomy. In the emergency, there was a tumor in the neck and there was a lot of stridor there. Without doing anything, just under local, I did a percutaneous tracheostomy. But if the patient is on an NIV, better to intubate give him sedation, paralysis, under control condition, you should do it. There are studies, there are people who have done this, but I don't think it is required or there is any advantage of doing like that.
Dr. Neel, would you like to tell us something about ProVent?
Hello. So basically, the ProVent COVID study, it was a study done in February 2021 in Netherlands. Basically, the study was specifically for in 18 ICUs across Netherlands, where they evaluated more than 1,000 patients who had post-COVID ARDS. And initially, it was a study which was only to understand the ventilatory parameters and what are especially in post-COVID ARDS, what are the ventilation strategies that will help. So what they found in that study was that to some extent prone ventilation, lung protective ventilation, and using driving pressures, that did help in salvaging a lot of patients of severe ARDS. This study was published in the Lancet. From this same study, there was a post hoc analysis which was published later on, which evaluated the utilization of tracheostomy. So what that study did find was that using any form of tracheostomy in those patients at that time in post-COVID ARDS, the median time was of around 21 days. So they evaluated the difference between less than 21 days and more than 21 days. So what they found was in patients where there was a tracheostomy done before 21 days, there was a shorter duration of ventilation. However, the duration or the mortality was also higher in such cases. That in post-COVID ARDS cases, there was a relatively higher mortality. This was again from the post-hoc analysis of this study. However, their recommendations was not that this does not mean that 21 days you should do the tracheostomy later only, but there are more studies which are needed to evaluate whether if they used a lesser threshold, like if at all in such cases an earlier tracheostomy was considered, then would there be any difference or not, that we need to evaluate. But definitely in this particular study, in that analysis, what they found was that the mortality was higher in patients where the tracheostomy was done in less than 21 days. So that was the ProVent COVID study, which evaluated the ventilatory parameters in post-COVID ARDS.
Right. Thank you, Neel. So, Dr. Chawla, coming on to the most important and the final question from my side, at least, that, of course, we have a few other questions which we'll take subsequently. I think most of them have already been answered. But this most important question, what is your protocol to decannulate a tracheostomized patient? I mean, when, how, what to keep in mind, whether you downsize the tubes or whether you just yank it out. What will be your SOP that you follow in your ICU?
The first thing is patient should be medically stable. That's number one. And the primary indication for tracheostomy result, was it secretion? Was it increased sedation requirement, or what was the indications? And the ventilatory parameters, they are bare minimum, or patient is on a T-piece, he's without ventilator. When you have reached this stage in a ventilated patients, after 48 hours, we just wait for 24 to 48 hours. And then I ask the patient should be conscious. He is not on any very high doses of vasopressor. 2-3 mics is not a problem. Then he can communicate, and he has got a very good cough reflex. And that is and minimal pulmonary secretions, which he can really handle. Then that is and his oxygen requirement. If he's on a T-piece and oxygen 3, 4, 5 liters, less than 40%, then I just pull it out. That's the usual. I think almost 70% of the patients in the ICU, when we do tracheostomy, we are able to pull it out. 30-40% patients who are on a prolonged tracheostomy tube, they have been using this for more than a month and a half. These are the patients where you have to go a little slow. All these, what I mentioned, they must be fulfilled again. They should be stable. They should have enough swallowing. Then what I do is, there are two ways. One is that we deflate the cuff. and we just see whether he can handle with the deflation. He can cough out, and he can swallow. There is no aspiration occurring. Then you just take it out. If a person has secretions, you feel only the tube is there for secretions, then you need to keep it. But if the secretions are less, most of our ENT colleagues, what they do is they downsize. They will put a smaller size tube, and then they may block and see whether patient can cough out from the mouth. And if he's doing this, you just take it out. But in ICU, I can tell you, I don't use this. Most of the time, what the technique I said, most of the time, these are enough. You don't have to downsize. But even if you are in a habit or your unit is in that habit, that's quite okay. You can downsize 8 to 7 and see if patient is all right. And then when you go to 7 to 6, if patient can handle secretion with a uncuffed, you put a without cuff tube, so that it is only for removing secretions, and secretions are not enough, then you just take it out. So these are various ways you USA journalized to have effective cough reflex, minimal secretion, stable, and successfully tolerating the cough deflation. You can take out the tube.
Absolutely right. So apart from all these measures, I think just one piece of advice, that also ensure that the patient is still not aspirating. If the patient is aspirating, then again, there's a risk of again going back into the same state that the patient had come in. So what we usually do is, as Dr. Chawla correctly said, that if it is an acute stage, then you would monitor the patient for 48 hours, 72 hours, and yank it out in the ICU only. If it's been a prolonged situation, then we would downsize, bring it down to a size of 5, see if the patient is okay, not aspirating, then strap it and see. And if that also patient tolerates successfully, then take it out and then consult the ENT, whether it needs to be sutured or not sutured. If it heals on its own, well, you're through with it. So before I thank everybody, I'd like to take some questions from the audience also. There are lots of questions that have come our way, except that I feel that some of them have already been answered. So first question is from Dr. Vishal Singh Chauhan. So Dr. Unnati, this is directed to you, that please explain the difference between the use of fenestrated and the non-fenestrated tubes.
So simple, as the name suggests, fenestrated tubes are basically, they have additional aeration pores. So fenestrated tubes could be used in patients wherein you are going to keep the tube for a longer duration. Non-fenestrated tube is usually the routine tubes wherein you have a single lumen, usually used in the tracheostomy tubes.
Right. Neel,
another thing which Vivek, I would like to say that, when you are managing a patient in the ICU, do not bother about the speech. Speech and all these are for chronic patient, laryngectomized and all those where patients where they had surgery, the tube can't come out or a very, very long time, then and everything else is okay. But in ICU, I think the safety and the survival of patient is more important. Don't venture into things. Sometimes somebody said also there was a problem. So don't venture into speak, because you can always ask patient to write down, because in few days time the tube is going to be out and he's going to speak. So that is a piece of advice. Then do not, because the relative would say make him speak, but if it's a short term, there is no worry. Just hold on.
Yeah, absolutely right. So this is exactly what I tell my patients too, that you have to choose between a superfluous aspect of speech versus saving life. What would you prefer? Speech can come back anytime. The moment you take the tube out, the patient will be able to speak. So coming back to our set of questions. So Dr. Neel, the next question is from Dr. Vasundhara Raki from Delhi, that why only do you prefer the site of second and the third tracheal ring? Why not below that or above that?
So below the third ring, normally the risk of injury to the vessels, there is the brachiocephalic trunk which comes below, just above the sternal notch here. So you don't want that during the procedure there is any major vascular bundle that you'll hit. So that is based on the studies where they have compared the best site for percutaneous tracheostomy as well as the risk of bleeding problems which can occur. So that is why the specific site is between the second and third, or in some cases even between the first and second. So two approaches, either of these two sites can be utilized in the percutaneous approach that way.
Bhavyaja from Maharashtra, Mumbai has quite a few questions. So I think most of them have been answered already. The selecting percutaneous versus surgical tracheostomy, we've dealt that in detail. criteria and techniques of decannulation. We've dealt that already. Then what about the high-risk patients and points to consider? We've discussed this already. Dr. Tampi has described it in detail. When to do a closure of long-term tracheostomy. Also, we've discussed different types of speech devices. We've discussed, are these my questions that you're repeating already? This is, we've already discussed all these questions. So then we have a question from Jai Kishan that how often, Dr. Tampi, have you had to do a tracheostomy in a patient with vocal cord dysfunction?
Uh, I have not had any such occasion to do a tracheostomy in a vocal cord dysfunction. But yes, in an acute vocal cord dysfunction, such as an adductor paralysis or abductor paralysis, a tracheostomy should be done as an emergency procedure, if not an elective one. Because one should not take a chance in such a problem with the main airway. So I would say that the absolute indication is the onset of the vocal cord paralysis rather than pure vocal cord dysfunction, which may not be a critical situation.
Right. So, most other questions we have from Anand, from Kerala, from Sanket. Sanket and Anand, we've already dealt with all these questions, that what are the high-risk patients, situations, optimal timing, indications. We've done this already. Indications for changing tube. So Neel has already spoken about it, that ideally it should be around third or the fourth week. If it is soiled, then you may want to do it earlier. If it is blocked, you may want to do it earlier. Otherwise, you could wait and defer, because ultimately you have to wait for the stoma to heal also. In the initial stages, if you take out the tracheostomy and change it, the stoma may just collapse suddenly and not give you any space to push the new tracheostomy in. So there you may have to use what is it called? A catheter, like a bougie kind of a thing, to provide you the pathway for the tracheostomy to be threaded over. Then we have Rita from Maharashtra. What are the indications of tracheostomy changing? We've discussed this. Cannulation, we've discussed. Tracheostomy-induced subcutaneous emphysema, we've discussed. What are the risk factors for tracheoesophageal fistula? So I think most of these questions have already been discussed. And in case you missed all these questions, I'm sure there will be a live YouTube, not a live, but a YouTube link also to this webinar that we've had, which you can easily access subsequently too from the ICS website. So with those words, I'd like to thank each one of my extreme. Yes.
Vivek, I want to say something. You've conducted very well. The only thing which my advice to everyone is, you should have an ENT surgeon as a friend. If you're starting, you should, because if there is a trouble, you should be able to call him. This is also very, very important. Although we did not require it, but you should always have somebody with you, because there are problems which are unforeseen, can come sometime, particularly when you are starting the tracheostomy.
Absolutely. A very good advice to everybody, that have an ENT surgeon or a thoracic surgeon as a backup available. Anytime you get stuck, I remember we initially got stuck with a lot of bleeding. So we had to take the help of their cautery machine to control the bleeding locally. But of course, you learn with experience. The learning curve varies from individual to individual. So with those words, I'd like to thank each one of my brilliant panelists this evening, who've actually described each and every step of the tracheostomy so beautifully, tackled all the complications, and from the time when the tracheostomy was inserted to decannulation, I think we've covered everything possible. There's nothing left at all for anybody to, even rethink or reconsider. So Dr. Tampi, Dr. Unnati, Dr. Abha, Dr. Neel, and of course, above all, Dr. Rajesh Chawla, for setting the ball for us rolling. And thank you, each one of you. Thank you, ICS. Thank you, Dr. Amita, Dr. Rajadhar, Dr. Sandeep Salvi, for giving us this huge platform. And of course, Cipla for supporting us all through. I think, if I'm not wrong, we've had some 1400 plus viewers this evening. We'll get the exact figures soon. There's another record-breaking figure, and I'd like to thank each one of you, because it's your eminence that has got us such huge audience this evening. Thank you so much. Thank you, all of you. And I think we can log out now till the next ICS webinar on ICUs. Thank you.
sir.
Thank you.
Thank you.
Thank you so much.
Thank you very much.
Thank you,